Peter Kellison on behalf of Walgreens. Similar to what the prior witnesses say, and we appreciate the department's acknowledgement that the dispensing fee component needs to be addressed and remedied by April 1st of 2017. This is as much of anything a timing issue, as there will be cuts on the ingredient end side taking place now, and as was said, would like some relief so that it's balanced and it's not an entire liability and exposure to pharmacies for a year while we come up with a different fee.
Thank you.
Mr. Chair and members, Don Gilbert representing Rite Aid stores. Similar, or actually the same concerns, but to give you a little more detail, the dispensing fee right now is $7.25. That's what a pharmacist gets for his or her professional services. In Idaho, Alabama, Oregon, you're looking at $12, $14, $15. Obviously, the cost of doing business in this state is much more significant than in those states. So to extend the baseball analogy, we got a fastball coming right towards our heads, and we're looking for a little help, so maybe we just take it in the ribs rather than in the head. Thanks.
Thank you, I think.
Mr. Chair, members of the committee, Kevin Pedrati representing CVS Health. I'm not going to repeat what all my colleagues said, but I will concur and ask that you leave this item open. Thank you.
Thank you. Any other public comment? I'm not going to mess with the baseball analogy on this, but Ms. Kent, I would ask if you would speak to the concerns that have been raised about timing. Obviously, we have federal regulations that we must comply with. This committee has expressed concern about the consumer and the end user. I did hear one of the speakers say that it would be hard for some pharmacies to stay in business. Do we anticipate negative impact to consumers as a result of this action? And can you speak to the timing that has been raised as it relates to other changes vis-a-vis the dispensing fee or any other matters that were raised?
I think I don't think that the concerns raised are inappropriate. I think it is the timing in terms of the way the federal rule was drafted. And so the changes to the ingredients and the payment of those those FULs have been both put in place and imposed on a lot of these drugs that were referenced just a minute ago. And those are effective in April of 2016. So the cost savings that we're seeing in both the current year as well as in the budget year are due to the ingredient federal upper limits being imposed. I think because of the dispensing fee being lagged behind it by a year, I think that is just an awkward timing. I think there's nothing from a federal perspective that we feel that we can do as a department to change, obviously, the payment on the ingredient side. And I don't necessarily know if there's anything that we can do to speed up the analysis and study for how we would figure out what a dispensing fee is, obviously, because we'd also have to come through the budget process. I think, we are committed to working with the pharmacies and the others in terms of if there are specific either concerns or changes that we could contemplate, but I don't know that I have anything at this particular moment in time to say that, yes, we see an access problem, or do we have a solution to kind of get us through this next year while we do the work that we need to do on the dispensing fee.
Is there a work group or some way that you're working with the sector? I know that you've convened a number of work groups, and we've often asked sectors that we regulate to really help us think about how to get to the end goal of helping the consumer, but also working with those in the sector. And I think the MCO tax is probably a great example. Is there a framework for how to have that conversation going forward?
I don't know offhand. I'm happy to go back to my pharmacy division chief who's leading the effort and ask who they're working with. I think they have regular, both meetings and discussions with all the various stakeholders that are both here and elsewhere in the state. I don't know if it is officially like a true stakeholder advisory group, but I can certainly go and check with them and see what they have in place and report back.
Thank you.
Mm-hmm.
Unless there's anything else, we'll move on to issue number 7, amendments to Program for All-Inclusive Care for the Elderly, the PACE program, PACE Modernization Trailer Bill.
Right. So I think that the write-up done by your staff was certainly really did a nice job of capturing the issue well. We have been in discussions with the PACE organizations for quite some time about moving them into a rate structure that is more similar to how we pay our Medi-Cal managed care plans, recognizing that PACE organizations are different than Medi-Cal plans. And so I would note that the main key things that we are really focused on working with them, and we've been having a lot of discussions with our financing staff and our actuaries and the PACE organizations themselves, is how do you account for the costs that are unique to them and both capture it and account for it in the building of the rate. There are also concerns about from the industry about just the transition of how this rate structure will impact them and change fundamentally the way that they have been paid in the past. And then also, I know that there have always been some geographic considerations that they have been concerned about. How we set rates on the Medi-Cal managed care plan side is that each rate for each plan is set on their cost and utilization and encounter data. So they provide us data on an annual basis, sometimes more frequently if we need it because we're doing a, in particular, like say we're doing a kick payment or something, but they give us all this rate work. Mercer takes all of those data points, they build a rate, they trend it, they account for certain either cost factors or changes in policy, and then those draft rates are presented to the plans, and then obviously we finalize them in the budget process. We would anticipate doing the same thing for the PACE organizations, but obviously they are slightly different than a managed care plan in that they are a facility with people that they are directly serving and providing service to, and so I think we are getting close to an agreement on that language of how we will be developing that rate, but I think we still have a couple more conversations with the organizations themselves.
Thank you. Anything from finance, from the LAO's office? Any committee member questions? Any public comment?
Mr. Chairman, members, Fred Main representing CalPACE, the statewide trade association, on behalf of the 11 PACE organizations in the state. First, I want to concur and compliment the department under Director Kent. The dialogue has been very, very good on the trailer bill language, and the PACE organizations understand and support the concept of moving to experience-based rate setting, and we've been involved in those dialogues now for at least since the first of the year, if not specifically, if not longer. We do think that there are 4 distinct issues still that need a little bit more tweaking, and I'd just like to raise them in the committee quickly. The first one is for the PACE participants who are dual eligible, they are paid, the PACE program is paid a Medicare based rate and then a Medi-Cal based rate, and the PACE organizations are very concerned that the Medicare portion of that rate is appropriately accounted for in setting rates and able to use their cost savings from the Medicare rate for the benefit of the PACE program. We met this morning with the department and its actuaries. I think we're close on that one. Director Kent mentioned the issue of geographic disparity. There have been issues that we believe in counties around the state where access to services has led to lower rates. We want to make sure that that issue of geographic disparity is appropriately addressed in an experience-based rate setting. We're still looking closely at that and maybe close on that. The final 2 issues go to kind of the transition from this current rate setting method. For both the department and for the PACE programs, I think we would both acknowledge we're going into new waters as to how this experience-based rating works specifically for PACE programs, and there is transition language in the trailer bill allowing the department the authority to use that. We would ask that it be a requirement that there be a transition, not just authority, and then finally for new programs, similarly, that they are recognized for a 1-year period with that transition. Thank you very much.
Thank you.
Peter Kellis on behalf of St. Paul's PACE program in San Diego. Want to express appreciation for the department's willingness and diligence in working with us to come up with something that's acceptable. Almost there. Echo the previous comments.
Thank you.
Mr. Chair and members, Don Gilbert on behalf of CalOptima. CalOptima is a county organized health system in Orange County. We have a PACE program. Concur with all of Mr. Main's comments, in particular with regard to geographic disparity, and appreciate Director Kent's comments on that subject as well. Thanks.
Thank you.
Mr. Chairman and members, Brian Lundgren on behalf of Innovage, a San Bernardino County PACE program. I agree with the previous public comments and also support the staff recommendation to keep it open. Thank you.
Thank you. Any other public comment on this item? Seeing none, thank you. We'll move on to issue number 8, the new Qualified Immigrant Affordability and Benefit Program trailer bill.
Sure. So this was a initiative that was approved, I believe 2 years ago, and we've been in the process of working with our partners over at Covered California. So in essence, individuals that are newly qualified immigrants would, instead of having coverage through Medi-Cal, they would be receiving coverage through Covered California plan product. Medi-Cal would be actually paying for the cost of that, and then we would be responsible for the wraparound of services or copays to the extent that there were any. It is extraordinarily complicated. It has been difficult to implement, and I think that what we had heard both concerns from stakeholders about whether or not certain issues had been adequately addressed, and then also in discussions with our partners at Covered California, the systems and the challenges and the translation of notices and other things were simply not going to be able to be accomplished on the time frame for which we had already set out. So we are proposing as a delay into January of 2018, and so that's what the trailer bill is really recognizing, is that we just need a little bit more time to kind of work through both some of the implementation challenges as well as allow for the programming of the eligibility systems.
Thank you. Anything from Finance, from the LAO's office? Committee member questions? Ms. Kent, would you explain again why this program exists, given or differentiate how it's different from what someone might receive if they're enrolled in the Affordable Care Act, and why wouldn't we enroll someone who's newly qualified in the Affordable Care Act?
Can I call Mary Cantwell? No.
You can call her a reliever.
I can call her, but she's not going to answer.
If you want to give us your best interpretation.
This dates back to when I was not within the department. I think that there were a couple of populations, and I'm sure Linda and others may correct me if I'm wrong. There are individuals who are within the 5-year ban. Is it within the 5-year ban?
5-year bar.
5-year bar. 5-year bar, sorry. And so there was a decision that at least the idea at the time was that they would receive and have more affordable coverage if we paid for their coverage over on the Covered California side, and then to the extent that they had benefits or other costs, then Medi-Cal would pay for it. But otherwise, it was considered to be a savings on the Medi-Cal side rather than including them on the Medi-Cal program. I think obviously it was certainly well intentioned. It's just taken us longer in order to actually implement it. And so I think that there was also an attempt to do a similar thing for populations for women that are pregnant. So obviously we are doing some pregnancy wrap services for individuals that are otherwise eligible for Medi-Cal and Covered California, because again, these are populations that churn based on income, and we have different income standards depending on certain status. And so this is just one of those items that we are still not fully implementing from 2014.
I'm getting a signal that the Western Center and the Department of Finance want to assist you further.
Oh, you know what? And I will gladly cede the floor.
So, Mr. Chair, Guadalupe Manriquez with the Department of Finance. So currently, newly qualified immigrants, Medi-Cal coverage is 50% general fund and 50% federal funding. So the RAP, they would get coverage and subsidies through the exchange, so it would be general fund savings for the Medi-Cal program.
Thank you. Anything from the LAO's office? I think the Western Center, this just in, there might be something from the Western Center.
Linda Way with Western Center on Law and Poverty, and we certainly appreciate the department's efforts on delaying NQI for another year, as there are some policy issues that need to be worked out. One point to clarify regarding your question, the chair's question, is that currently individuals up to 138% of the federal poverty line are eligible for full scope Medi-Cal, and the state currently provides that for those who are newly qualified immigrants, so those who meet the 5-year bar, and so are proposing to transition these people from full scope to Covered California, although their counterparts are currently eligible for full scope Medi-Cal right now. And so we do support the administration's effort to delay this because they are policy questions. Would note that the trailer bill language has some policy changes in the language, and we think that this should happen in policy committee. We look forward to discussing with the department some of these policy changes now that we have the time with the delay, but don't think that that should be in trailer bill language. In addition, the trailer bill language also proposes delaying the need to promulgate regulations out for another 2 years, while a delay may be beneficial. Now that we have the time, we don't think it needs to be an additional 2 years. So do look forward to working with the department, but do have some concerns on the trailer bill language.
Thank you.
Kimberly Chen with the California Pan-Ethnic Health Network. Want to echo the comments by the Western Center on Law and Poverty. Also want to express our concerns about some of the policy changes being proposed in the trailer bill language. The items like the translation, those things need to be worked through. And I think the things that are being proposed in the trailer bill language are appropriate to discuss as we look at the implementation and other things that might need to be adjusted. And so request the committee to reconsider those moving forward.
Thank you.
Good afternoon. Tam Ma with Health Access California. I want to echo the comments of my colleagues at Western Center and CPEN. We very much appreciate the department and the administration delaying the implementation of the NQI RAP by 1 year. We do have significant concerns about the policy changes that are proposed, and kind of like in a nutshell, trying to move people from Medi-Cal to Covered California, two programs that have two very different enrollment and eligibility requirements and systems in place is very complicated, as Director Kent stated. We have a lot of policy questions and concerns, and we think that all of this discussions about policy changes should happen, outside of the budget process, and be able to kind of discuss all the policy concerns together, just because when you make one policy change, it impacts other issues within the program. So we'd like to kind of consider all those things holistically, and appreciate the staff recommendation to keep this item open. But to be clear, we do support the 1 year delay, but would oppose making the policy changes at this time. Thank you.
Thank you, and thank you for breaking down the complicated issues here. That's Tam Ma, everybody. Once, a long time ago, she was my student. Now she's educating me on complicated healthcare issues. Thank you, Ms. Ma. We're up to the ninth inning. You're doing very well, Ms. Kent. Thank you. Issue number 9, Emergency Medical Air Transportation Act Cleanup Trailer Bill.
Sure. And this is actually one that I actually know something about, so this is good. So there was a bill back in 2010 in that the air ambulance providers were looking for a rate increase and how they could find a non-federal share to draw down federal matching funds. And so there was an approval by the legislature and signed by the governor at the time to enact a $4 penalty on vehicle violations. This has drawn in several $1 million, or actually more than that, so what we're doing is we've enacted a supplemental payment program for these providers. When the authorization came back around, I believe it was last year, to continue this fee and this assessment, there was language that was placed in the bill at the end of session in which we found it to be somewhat problematic, in that it said it was incumbent on the Department of Finance and the Department of Health Care Services to try and do a report to identify some other kind of funding source. We believe that that's no longer, or it's just not necessary, and so we're proposing to strike that in its entirety from the statute and just continue with the current assessment and the ability of us to continue drawing down federal funds for these providers.
Thank you. Were you going to add additional testimony?
I wasn't sure if I should sit here or wait. Catherine Scott with the Air Ambulance Providers. We sponsored SB 326 last year and did commit to, in the process of this bill, working through the governor's office, commit to working on this language, because Department of Healthcare Services expressed extreme concern about the language and the resources required, as well as how the language could move forward. So we are committed to continuing to work that out with the department and remove the department as the entity to do the report. But we are willing to work with the Assembly on other language if necessary.
Thank you. Anything from Finance? Anything from the LEO's office? Any committee member questions? Public comment? Any public comment?
Jump the gun.
Well, that concludes all the issues for your department, Ms. Kent.
At least for today.
As we
Well,
say,
actually not for today. There's a couple more coming. But.
as we say in baseball, you hit the cycle. You touched all the bases. So thank you.
Great. Thank you.
Issue number 10, Continuum of Care Reform, Specialty Mental Health, Issue 561. We welcome Karen Baylor from the Department of Health Care Services. We'll have Finance, LAO's office, and public comment.
Good afternoon. I have to say relief pitcher for the director of DHCS.
Would you at least let us know who we have the honor of having as relief pitcher? Welcome. We're glad to have you.
Thank you. The department is asking for $6.5 million.
You have to introduce yourself.
Oh, I'm sorry. Karen Baylor, Deputy Director, Department of Health Care Services, Mental Health Substance
You're
Use
who
Disorders.
we were expecting. There's no relief. Go for it.
Now you threw me off. The department is requesting $6.5 million for the implementation of the continuum care reform. The department's been working very closely with our sister department, the Department of Social Services, in implementing the continuum of care reform. And this money will go to 3 distinct items. One is for the county mental health staff to participate in the child and family teams, which has to do where it's a child-centered kind of meeting where they discuss interventions and treatment planning in order to make sure that the child is placed in the most appropriate placement and getting the services that they need. Secondly, it's for additional assessments for the county mental health staff clinicians to conduct if needed. And then third is for training of the county mental health staff to implement CCR.
Thank you. Anything from Finance, from the LAO's office? Committee member questions? Public comment? Any public comment?
Kirsten Barlow with the County Behavioral Health Directors Association. Wanted to acknowledge and thank the administration for adding a larger scope of the county mental health plan responsibilities that CCR envisions for our system. However, we do have some substantial concerns or questions that we're hoping to meet with the administration on over the next week or two to ensure that our comparison, that we compare apples to apples in terms of the numbers of kids, the types of role that the administration really wants county mental health system to play, because currently, even though the May Revise does provide some additional state general fund resources, they're still very limited to only a small scope of children who have serious emotional disturbances. It's our understanding, though, that the administration and many stakeholders' hopes for CCR would be that there'd be a pretty substantial difference in the amount of mental health clinician support of children in the child welfare system beyond just those kids who would be in those highest level group homes. So we're hoping to find a way to meet in the middle in very short turnaround time with what remains of the budget season. Thank you.
Thank you. Any other public comment? Seeing none, we'll move on to issue 11. We welcome Ms. Baylor to continue its drug Medi-Cal rate setting process trailer bill.
Thank you. This is in order for us to be able to provide information via information notice or bulletin authority for the rate setting process. Currently, we have to do emergency regs, and so we're requesting through this trailer bill to be able to publish our rates through bulletin authority rather than emergency regs, which will be an extreme administrative efficiency. So that's our request. Thank you.
Thank you.